Thanks to everybody for putting on your video if you can. It'll make it a little bit more like a brainstorming session if we can see who we're talking with. Karen. Last Tuesday, she was on there a second ago.
This is Mcallister. Our internet got knocked out by a
School of Medicine at Emory. And as far as the CTSA is concerned, I direct the Collaboration and Multidisciplinary Team Science Core. So this is an event that we put together to try to bring folks who have similar interests together and maybe haven't worked together before. And the idea is it's largely a brainstorming session. The conversation is going to go wherever you take it, but hopefully we'll be able to come to some commonalities in vaccine hesitancy that perhaps we can tackle. Noack, who's the professor of advertising and public relations at University of Georgia, to kind of set the stage for us. Then we'll ask each of you to introduce yourselves, tell us your interest in vaccine hesitancy, and then we're just going to talk and we're going to figure out what are the burning questions in the field, and where are places where we can collaborate to address the issue of vaccine hesitancy. So with that, does anybody have any questions before I turn it over to Glenn? I know some of you have done this with us before, so welcome back. All right, Glenn, go ahead.
Sure, and I'm sharing my screen. Can people see it?
We can.
Although not the way I want you to. I can't get PowerPoint. Let me just do this for a sec. Oh well. So I'm Glenn Nowak. I'm the director of the Grady Center for Health and Risk Communications and a professor in the Department of Advertising and Public Relations. I was at the CDC for 14 years, including 6 years as director of communications for the National Immunization Program at CDC, 6 years as their director of media relations, including during the H1N1 pandemic, and then spent a couple of years as senior communications advisor to Dr. Ann Schuckett, who was the director at the National Center for Immunization and Respiratory Diseases at that time, and then rejoined the faculty at the University of Georgia in 2013 as a full professor and director of the Grady Center. I have stayed actively involved in vaccine-related research and efforts, working with people at CDC, the Task Force for Global Health, the World Health Organization, UNICEF, on a wide range of vaccination issues and challenges. And so I did, including in particularly vaccine hesitancy and acceptance. I thought it'd be helpful to just kind of walk through a few things to help people to set the stage for today's talk. And let's see. There's been a lot of interest in COVID-19 vaccines. Back in December, before we had vaccines made available for emergency use authorization, there was a lot of questions about vaccines, about these COVID vaccines. There were concerns that were being expressed by a wide variety of people, including on safety and effectiveness and how well these vaccines would work. And we have since learned a lot since December of 2020. And there's still that ultimate question of, we may soon have a COVID-19 vaccine, but will enough people take it? So that still remains today a concern. When it comes to vaccine hesitancy and addressing vaccine hesitancy, including for COVID, I think it's really important to understand a few things. It's really important to know and understand the commonly used terms in this domain. The most widely used terms are hesitancy, confidence, and acceptance. It's important to understand that vaccine and vaccination are not the same thing, and that can get really confusing if you just take those two terms and you link them with hesitancy, confidence, and acceptance. So people can be hesitant about a vaccine And typically, if they're hesitant about a vaccine, they will be reluctant to get that vaccine, which is vaccination. Some people have complete confidence in the vaccine, or they say they do anyway. Flu vaccine is a really good example of that. So they will say, I don't have any doubts about the safety of that vaccine, but I'm not interested in getting the vaccination because I don't think it's going to be beneficial. There are a lot of factors that facilitate and inhibit vaccine acceptance, and hesitancy is but one of them. And so it's really important to understand that there are a lot of things that affect acceptance rates and whether people delay vaccines or don't delay vaccines, including COVID vaccines. The COVID-19 vaccination landscape is incredibly complicated. It's not a very simple one. If you're going to do work in the space of COVID-19 vaccination hesitancy, you need access to vaccination records. And that means that you're going to have access to medical records. The other thing is that vaccination records are often scattered, particularly when it comes to things that involve adult vaccines. And COVID vaccine is no exception. In fact, there are more places you can get COVID vaccination. So COVID vaccination records are scattered. They can be at CVS, they can be at your employer, they can be at your primary care provider, they can be anywhere. And it's not always the case that those records are aggregated and centralized. There's a lot of expression about the importance of doing that and the value of doing that. It is very difficult to aggregate vaccination records when people can get vaccinated at different places. And there's been a lot of work that's been done. And I think it's important that if you're going to work in the space, that you realize that there's been a lot of surveys, at least 45 published surveys have been done. There have been multiple studies on multiple topics, and a lot of resource kits have been made available, including trying to capture and reflect what's been learned from behavior and social science, or what behavior and social science insights can be applied. In terms of the terms, the common terms, vaccine hesitancy, there are many different meanings, but usually the one that we're talking about at the end of the day is someone's reluctance to get a recommended vaccine or vaccination. There are definitions out there that are based on behavior and basically say that if somebody delays a vaccine or doesn't get it when it's otherwise available, that's hesitancy, but that's a really messy definition. And it doesn't take into account that there are many reasons people delay or don't get vaccines. Confidence often refers to the strength or faith of belief that receiving a recommended vaccine will bring significant benefits, and there's very little likelihood of a bad or negative outcome, such as adverse reactions, immediate reactions. Negative outcomes for many people include, I'm going to feel crummy 3 or 4 days after vaccination, I'm going to have a sore arm. So it's not that they're necessarily all fearing really long-term negative outcomes. Things that would inconvenience them are often cited as something that impinges their confidence. And then there really has to be a strong belief that the benefits of receiving a recommended vaccine or vaccination far exceed possible risks. Vaccine acceptance, two common definitions are, it's agreeing to receive a recommended vaccine, and that's often measured through intention measures or actually getting vaccinated. And for that, we look at vaccination records. And then herd immunity has often been kicked around, cited, mentioned when it comes to COVID-19. Herd immunity can mean a number of things, but bottom line is it means when a large part of the population of an area is immune to COVID-19, the virus will have nowhere to go in terms of further transmission. Herd immunity is a challenging idea when it comes to COVID-19 vaccines because we don't know if we'll ever be able to achieve it. And it also brings to mind for many people a stable end state. And as we have seen with things like flu, one, we might not be able to achieve herd immunity, and two, it may be a relatively brief state depending on virus variation. These are the relationships that people often have in mind when it comes to hesitancy, confidence, and acceptance. The general idea, and this is not the only way people look at this, but one way of looking at this is that confidence is related and drives hesitancy, that if I'm very confident about a vaccine, I will be less hesitant. I will be more likely to accept it, and that will result in higher immunization rates. Conversely, if I have low confidence, I will have greater reluctance, I will be less likely to get the vaccine, and I will have lower immunization rates. A number of things have been found to affect confidence and hesitancy. And they include trust in government or lack of trust in government, trust in experts or lack of trust in experts, and the same thing for public health and mainstream medicine. We also know from a lot of research that's been done, there are important influences either on trust or directly on confidence and hesitancy. And a lot of things have been studied. They include political identification, moral values, past experiences, and that can be with healthcare services, with a disease, with government services, with discrimination. Any number of things can play a role. Health-related beliefs, social networks, and then media sources used for information. I mentioned the COVID-19 vaccination intervention landscape is complex, and it's often more challenging than many people realize. There are uncertainties regarding these initial vaccines. We know a lot about their safety and effectiveness. We don't know as much about the duration of protection. We now know that they're widely available and local availability looks good, but demand is highly variable. We know that people's trust, credibility, and health information seeking is strongly connected with moral values, political beliefs, and/or past experiences. We know that wide variations in COVID-19 disease effects and impact, those things affect people's individual perceptions and beliefs, particularly younger people. We have 2-dose non-interchangeable vaccines, which is something that's much different than with most of the vaccines that we've made available previously. There are differences in federal and state approaches and even local approaches. There are new developments and findings happening daily. So this is not a stable environment. It's a highly dynamic environment. We know that these vaccines have different requirements and different safety and efficacy and effectiveness profiles. And the whole thing means that we have a more complex environment. There are a lot of safety questions and concerns. So it's not just a simple matter of, is the vaccine safe? There are misinformation-based questions like, does the vaccine cause infertility? There are deaths that occur after vaccination that get a lot of media attention, and then you may not hear from them again. So this death of a Florida doctor got a lot of media attention. It's not ever been clear whether that had anything to do with the vaccine. We know that there were initial reports of Bell's palsy. Those seem to have gone away. We know severe allergic reactions got a lot of attention. They seem to have gone away. People will test positive. People will have symptoms after getting the vaccine. So there's a lot of vaccine safety questions that pop up. People often like to focus on beliefs and say that, people have the wrong beliefs. They may, but oftentimes it's the vaccine realities that create those beliefs, and those realities are true. So we know, for instance, that 18 to 49-year-olds do not suffer a lot of severe illness. And so the fact that they then believe that they're not susceptible to severe illness shouldn't be terribly surprising. How does that affect interventions? It means it's really hard to use severity of illness as the basis for an intervention when you're targeting a group of people for whom severity is not likely to be an issue. This is a slide from one of my papers I did a couple of years ago where we looked at confidence and we had some confidence measures. And I just put this up there to show you that you can find strong relationships between how confident people are in the safety, effectiveness, and benefits of a vaccine and whether they have got that vaccine. So you see very dramatic differences in that final column. One other thing I read this morning, there's a recent commentary talking about the need to be careful with the vaccine disenfranchised groups. This was a commentary from some people in the UK, but I think it's quite germane as they did also to the United States, that the challenge of low vaccine access and uptake by some groups is actually multidimensional. Vaccine hesitancy is often implicated, but the framing can be mistakenly place the responsibility on the groups and not on some of the big barriers. And they, in this article, point out that a couple of things that they have learned is that you do need to have insights from quantitative and qualitative data to inform your strategies to increase vaccination among groups with low uptake. But you got to make sure that you're addressing the right drivers. Otherwise, you're going to come up with the wrong solutions. Hesitancy typically implies that individuals or communities are choosing not to take the vaccine on the grounds of low confidence or incorrect beliefs. That may or may not be true. high mistrust of healthcare providers, public health and pharmaceutical companies, and structural barriers may be far more important. And if you don't address those, you won't actually make any progress in terms of vaccination acceptance. There's often no quick fixes for strengthening information sources and how people find information. But it is true that part of the solution often lies in finding out who are the trusted local healthcare providers and how can we get them to connect with the local community that has concerns to address their specific fears and counter misinformation. So working with communities is something that is a key component of vaccine hesitancy and vaccine acceptance interventions. I'm just going to finish by pointing out that there's a lot of resources and to highlight some of the, I think, the most important ones. One is the Centers for Disease Control and Prevention. They have, and they update on a regular basis, this COVID data tracker. This is from today, and the data is current through yesterday. And so you can see that there's been tremendous progress made in terms of delivering and administering COVID-19 vaccines. It's estimated 153 million people have at least one dose, and 116 million people are fully vaccinated. When it comes to the population of one population of high interest, people 65 and older, it's estimated 84% of them have received at least one dose, and over 70% of them are fully vaccinated. And you can see the biggest difference is the lack of impact on under 18, but that is something that has just been made relatively recently available. This data, however, if you go one step further, you see this. And what this shows is that there are significant race and ethnicity differences when it comes to a single dose administered. By far, most of the doses have gone to white, non-Hispanic adults, and rates for other race and ethnic groups are much, much lower. They are lower for one dose. They are lower for being fully vaccinated. The other thing I would call attention to with the CDC data is the fact that not everyone tracks race and ethnicity when it comes to who gets the vaccine. In the previous slide, 56% of people there was data for regarding race and ethnicity. For the fully vaccinated, it's 59%. And there are still places that do not track race and ethnicity data when it comes to COVID-19 vaccines. There are resources for talking to patients. So a lot of vaccine hesitancy interventions involve working with providers or working through providers to have better conversations with patients. And so the CDC has got a number of resources there. There are other organizations that have developed resources for providers as well. The National Academy of Sciences, Engineering, and Medicine has been actively involved in COVID-19 vaccine acceptance efforts. And these include 2 reports that came out this year, one in February on strategies for building confidence in COVID-19 vaccines, another one in understanding and communicating COVID-19 vaccine efficacy, effectiveness, and equity. There are organizations like the Institute for Public Relations that have looked at research theories, models from social and behavior science, and have put them together to help people who are designing interventions. And this is this is publicly available as well. If you go inside, they've got a number of different topics. And so you see there have been research efforts and there's needs in multiple areas when it comes to COVID-19 vaccine acceptance. There is the de Beaumont Foundation, which has been actively involved in trying to figure out how do people understand COVID-19 vaccine, and are there ways that you can communicate better and more effectively? And so they have developed a number of different resources based on research they have done, which includes focus groups and surveys, to offer advice and guidance on how to improve the conversation and how to change the COVID-19 vaccine conversation. There's the Immunization Action Coalition, which is partially funded by the CDC, which has an array of COVID-19 resources. They also serve as a clearinghouse for organizations to make their resources available to others. And then even in the New England Journal of Medicine, there have been articles on what needs to be done to promote COVID-19 vaccination in the United States. This one caught my eye because this was an example of some people looking at marketing and trying to take what we have known from social marketing and put it into a New England Journal of Medicine article to share strategies and steps with a broader, probably audience that's not as familiar with that literature. And again, I mentioned that there are lots of resources that have been created by different entities. National Institutes of Health developed, supported the development of a COVID-19 vaccination communications document. The Vaccine Misinformation Management Field Guide is one of about 5 guides I'm aware of that have to do with managing misinformation, responding to misinformation related to COVID-19 vaccines and vaccination. So these are the kinds of resources people need to turn to and be familiar with as they build out or try to build out interventions and proposals. And then there's been a lot of published studies and a couple of examples, and a lot of attention to conspiracy theories. There's an article in Social Science and Medicine that looked at some research. And then there's also been advice as to how to use social media to address misinformation. So there's a lot of ideas out there. That's the good news. Many of these ideas have some research basis. A lot of them do not. So there is also much opportunity out there in terms of the world of COVID-19. So that's the setup.
So thanks, Glenn. That's a lot of information to take in. Before we go into introductions, does anybody have any questions about the presentation they want to ask or start the conversation rolling?
This is Karen, just a dumb question. Any way that we can get a recording of this presentation or a copy of those slides? That was wonderful.
Sure, I'd be happy to. I'll share the slides with the folks and they can distribute them. I'll send them to Lauren.
Thank you.
Glenn, I have a question. This is Michael Erickson. Can you comment on why we only have about half of the race, ethnicity, identity in the surveys around vaccine? Because that seems to be a big gap in terms of what we know and the reliability of the data.
Yeah, so I think a lot of it has to do with that there was no real guidance at the beginning. And so unlike previous efforts like in 2009 H1N1 where there was a centralized federal effort, this turned out to be 50 states, and within each of the 50 states, multiple different approaches. And so some jurisdictions never collected race, ethnicity, and other data, other demographic data. They really just wanted to make sure that they recorded the fact that so-and-so got a vaccine. That was all they were worried about. And then other places had much better data collection processes and also were more likely to use immunization registries. So immunization registries are not uniformly used across the country. Some states have really good registries, others don't. And then providers, same thing. Some providers may not collect the data because they may have that data in another database. And so there's multiple reasons, but yes, I think a lot of it has to do with there wasn't guidelines at the beginning saying by anybody saying, best practices would be to do the following. And so people did what they either did previously or they just did what they thought made the most sense. And a lot of it was expedient. I mean, they were just trying to get vaccine in arms.
So I think what I'd like to do now is just ask each of you to introduce yourselves, tell us about your research in this area. And as you're telling us that, tell us what you think are the research questions that we might be able to tackle together. And so I'm going to go with whoever I see on my screen. And so that means Michael, I'm starting with you, Michael Erickson.
Thank you. And thanks for organizing this. And that was a fantastic presentation, Glenn. I guess the reason I logged on today was I'm struck by the both the attention given to the issue of hesitancy or acceptance and the data that's being collected being very descriptive of who is hesitant or not, but relatively little theory or behavioral science research informing interventions. And I'm like to see how do we test or apply what we know about health behavior, whether it's vaccines or other health behaviors, based on, long-standing theories or efforts to explain health behaviors that may or may not be relevant for the situation. But, I keep thinking back to one of the oldest theories that people use frequently for publications, something like the health belief model, which has as its basis people's perceptions of severity and susceptibility. Well, to me, that's really major issue here with COVID, that, some people don't think it's real and other people don't think they'll get it. And I don't know a lot of research that's being done to better understand from a health behavior theory research standpoint, how do we shape messages in a way that we know from previous health problems that might be useful. So that's what I'd like to get out of this, and also to follow up with. And last thing I'll mention is we're working on this issue in Clarkston, Georgia, refugee community with through our Prevention Research Center, CDC funded. And all of the prevention research centers just got a supplement this last week to focus on decreasing hesitancy and increasing uptake. And there's an effort to establish a network of prevention centers to share experiences.
Maybe a great interest to this group, actually, as you get further into that.
Great.
Hey, this is Alfred Mcallister. Since you won't see me on your screen, can I just blurt out and talk real fast?
Sure.
Okay. Hey, Michael.
Hey,
Long time no see.
Hey, Alfred.
Wish I could see you. I'm a native Texan, Stanford PhD, psychology, communication, postdoc, biostat, epi, taught at Harvard a few years, been in Texas a long time. I've retired from teaching, and I just work full-time as consultant, not full-time, both to local public health officials, former students, particularly in far South Texas. We got a 18 county area there that I'm very close with. And then I work with Foundry 512, which is an advertising agency, I guess you'd say, as their public health behavioral science strategist. And I do have some specific ideas and some theory too, Michael. I'm looking at your conspiracy theories and your like religious beliefs and stuff that are getting in people's ways, and we feel it's important to kind of like destigmatize conspiracy thinking or super religious thinking. They're natural, we'd like simple explanations for things, evil genius behind it all. And our focus that we're pushing is not so much the trusted local leaders as what we call peer models, which are people who, members of an audience, they'll look at them and listen to them, and they'll think, hey, that's somebody who, if I met them, I'd probably like them. They would like me, like so-called ordinary people. And we found, and they're not hard to find, people like that who have thought through, conspiracy theory or religious objections and rejected them. Frankly, I feel African Americans are being stigmatized as vaccine hesitant. Of course, they're cautious. Everybody knows the history, and it still goes on today. How poorly African Americans are treated in healthcare. But as I understand it, African Americans, once they think about it, study it, they're doing pretty well, and Latinos the same. What the at-risk population we see in South Texas, and we have very good data aggregated by county, so we can look at county level factors, and there's no doubt the most at-risk minority in South Texas is rural Anglo men, which actually I'm one, a rural Anglo men. And it has to do with political, cultural identity. It's complex. Don't want to go all into it. But I will tell you, 2/3 of my blue collar friends, because I have a wide friendship network, tell me that they'll never get the shot. It's a mark of the devil. It'll change your DNA. They're going to download spyware. It's your first step toward communist totalitarian 1984 state, and so this is an approach that we want to work with, is finding the peer models who've sort of recovered from misinformation and decided to get the vaccine. And I've got lots of anecdotes of people I know who that's exactly how they changed. They talked to somebody that they knew, or they overheard a conversation, somebody they liked, and way more than their doctor or some expert trying to tell them what's correct. So as a research interest, I'm not interested in publications. I could care less at this point in my life. I'm 72, but I am interested in intervention research where it's controlled design. In fact, we've got a proposal going out this early next month in South Texas to test interventions and see what impact you can get out of intervention. And be very interesting to test competing theory-based interventions. Though I'm far from want to lead anything like that, but I could sure contribute to it. So anyway, that's my blurb.
Thank you. Karen, you want to go next?
You say Karen?
Yep.
Hi. My name is Karen Melchis. I'm from Georgia Tech, a research center called the Center for Inclusive Design and Innovation. Since last summer, I'm representing my center, but I'm probably not the best representative. There are some other people that have been more involved with this up to now, but oh well, you're stuck with me instead. Since last summer, my center has been working with the CDC to look at how to provide accessible versions of their materials to people with disabilities, yet another minority population. That has included, captioning videos, doing audio description, but also doing simple language versions of some of the publications for people with cognitive disabilities. So they've been working on that. Recently, as in, I think last week, Friday, or something like that, they submitted a proposal to the Georgia Department on Aging to look at vaccine hesitancy. Not sure why it sounds like that's something that should have been done a month ago, but I don't know if we're going to get that project or not, but it's promising because we do have a relationship with them. In the case of people who are aging, people with disabilities, the issue may not be hesitancy, it may be access, or at least those two things sort of go together. But anyway, I'm here to find out what other people are doing and look at whether there might be some overlaps, because one of the things that we've been talking about a lot lately in our field has been intersectionality. So it's aging, and disability plus immigrants in Clarkston and or other subgroups. So that's why I'm here. Thank you.
Good. Thanks, Karen. Allison?
Sorry, I had to get organized here. Thanks to Glenn for telling me about this group. I really appreciate being the way you've invited all kinds of people to join in and listen. In fact, today I was just on a call with the University of Arkansas, and they were saying there's some effort for CTSAs to do joint research projects. So I don't know if you've heard that yet, but
There's always an effort for CTSAs to do joint research.
oh, okay. Well, she thought it would be great if we connected them in this group, but I work for a federal contractor, and we self-funded the president has a foundation and been funding groups in the South, mostly in Alabama, but she self-funded a project which we looked at a very conservative exurb of Atlanta, Cobb County, everybody's familiar with, 94% Republican voting for the last 3 cycles, and I think 94% Protestant white, mixture of income ages. And we did like a standard fear-based efficacy model on, we used a video, and then we tried to raise the risk perception to see if we could get people to wear masks and distance. And then we also asked a little bit about vaccines intention, but it wasn't at that point when we started it wasn't such a big factor. So our data isn't as much about vaccines, but I think it's pretty consistent based on what the caller from Texas was already also saying. And then I've seen the data since then, in this county that we worked in has very, very low vaccine uptake. And it also has a high COVID death rate. I think one of the highest in the state. So, so we looked at, we did also 2 psychological batteries, one on risk, the seeker versus averse, the risk battery that's been around forever, and then the conspiratorial ideation battery that's also been around forever. We got just a few questions for each, but we did that with Georgia State University political science teams and some of the public health. And anyhow, we did find movement on increased risk perception among the those high in conspiratorial ideation, which I thought was really interesting, and weren't surprised to see some movement on the risk aversion. Anyhow, I won't go into too much detail, but that was one of the things we were trying to look at: misinformed and uninformed population, but we didn't have enough money to get to the uninformed population, which is what we were calling them. But now we are looking into some grant funding to look at rural African-American population with very low health literacy rates, just general literacy rates, very rural, and just trying to do a little bit more. The grant source is about community-based research, but that's kind of our thinking anyhow. That's really what would make a difference. So we're hopefully able to get some funding to widen our approach there. But I was just interested in what everybody else is doing and wanted to share that. And I like this model. I did work with the PRCs when I worked for CDC, so I'm a little bit familiar with that. I think that's also a great idea. Somebody mentioned earlier, and Dr. Erickson mentioned.
I don't know if we have anybody here from the UGA agricultural. I forgot. Glenn, you may know the name of it. There's a group at UGA though who's focused on rural populations, and they have lots of different communities where they have people who are working with those communities. It might be a group that you should hook up with if you're interested in rural communities in Georgia, largely African American. I just can't remember the name of
Karen, would that be Extension Services?
Extension Services. Thank you. That's who it is. Yep.
They did my soil sampling.
They do other things too. And through the CTSA is working with them on some projects not related to vaccine hesitancy, but other things related to rural health in Georgia.
Great, thank you.
Jesus.
Look, can everyone hear me?
We can.
Okay, great. My name is Jesus Trujillo. I work for Foundry 512. I work with Dr. Mcallister, the one who brought up the idea about the onslaught of misinformation back in November, when I first started seeing a lot of communications coming out through various smaller community-based channels on the internet and social media, generally walking people how to refuse vaccine. And it was something that was brought to the attention of the Boundary 512, and we've been pairing with Alfred ever since to develop our approach and our execution for combating this public health.
So that's the first we've heard about social media. Don't know if anybody else has an interest in that as well. Mugisha.
Yes, hi, I'm Mugisha Nibizi. I work with the Georgia CTSA as well. I'm part of the recruitment center. So, I mean, we're interested in kind of understanding why people sign up for research studies and kind of health communication in that sense. But I feel like some of the solutions or the approaches we can take toward addressing vaccine hesitancy could be related also to increasing participation of people in research, because I think some of the same barriers and misinformation could exist. And so I'm just interested in hearing from more about that. But yeah, that's kind of my area of interest.
Thanks. Aaron.
Sorry about that. I'm also with Boundary 512. We're actually researching various reasons for hesitancy and resistance and shaping up what we call a national movement at the last mile called the Resiliency Campaign to help local communities, counties, cities, states target these special audiences, special interest audiences, and how to overcome that using Dr. Mcallister's peer modeling approach. It's just really interesting to learn all of the various nuances and reasons for hesitancy and different methods that might work to overcoming those fears. So we're just really thankful for the opportunity to listen in to everybody.
Okay, thank you. Chia. Dr. Wang, I may have.
Hi, how are you? Thank you for the opportunity. I'm a pediatric nephrologist at Emory and Children's Healthcare of Atlanta. New to vaccine hesitancy research, I have a small internal grant right now where we are surveying parents of children with kidney diseases on their attitudes towards the COVID vaccine, surveying and in-depth interviews. So I work with a very vulnerable population spanning from children with simple chronic kidney disease, single issues to end-stage disease with dialysis and transplant populations. My challenge in this field is trying to convince and grab some attention towards the pediatric population to convince folks of the importance of vaccinating both children as well as children with medical issues. And tailoring that message will be, and preparing a campaign will be very challenging, I believe, both to have tailored messages for the pediatric population and any issues specific to children with kidney diseases. So love to get any feedback. I do believe that this research is very timely and we want to be proactive as the vaccines are becoming available for children.
Thank you.
Thank you.
Aaron Joe. Aaron Joy, sorry.
Thank you. Yes, it's Erin Joy. I'm a staff member at Emory. I'm the associate director of the Emory Influenza. Well, I'm sorry, we've just changed our contract. The Center of Excellence in Emory in Influenza Research and Response. They have to change the initials every 7 years so that we can still be funded. However, I'm also a graduate student in public health at Georgia State, and that's why I'm here. My interest is vaccine hesitancy, of course, and I'm mainly here to learn.
So I'd ask you, what did you hear that someone else say that interested you or might ask you to, or it might interest you in further discussion or potential collaborations? I heard a lot about the model, the peer-based efficacy model, and I'm wondering if some of the studies in different regions of the country would be stronger if you work together with some common tools. But Glenn, you were about to say something, I think.
Yeah, I was going to say, people talk about, there's been a lot of theories applied. So just including the COVID, but there's been a lot of work in childhood, adolescent, and adult immunization. There's the last decade has probably seen thousands of studies. It is hard to persuade people who don't want to do something. I think that's that what these studies have shown overall is that people who don't want to do something are really good at not doing it. They're highly resistant. They will ignore you. They will counter argue. They just will not change their behavior. There's no magic intervention when it comes to people who are highly, highly resistant. Most of the efforts focus more so on the people who are on the fence, who are taking wait and see attitudes. There has been a lot of application of communications theories. Stages of change is one of them. The health belief model is tough because literally speaking, for most of the childhood vaccine preventable diseases, there is no susceptibility. Susceptibility is low because we have 90% vaccination coverage. So your child is not likely to get those diseases because vaccination rates are so high. The issue would become much different if vaccination rates plummeted. And the same thing, I'm at the University of Georgia. A lot of college students have told me they don't fear COVID. They've had COVID. They know people who had COVID. The data suggests that they have no reason to fear severe COVID hospitalization. So trying to use the health belief model to convince them that they're susceptible would be a really tough thing to do. I don't know that would work. But that said, there are other theories that I think are being used and applied. The other thing that people have found is that behavioral economics and incentives and disincentives for people who are hardest to persuade often work best. That if you have strong incentives, strong disincentives to do a behavior, you can get people to do the behavior. You probably won't change their attitude about the behavior or their beliefs about the behavior, but you will in fact get the behavior change that you're looking for. And in fact, in this country, and it's true across most of the world, well, we're actually somewhat unique in this country. When we had no state school laws for childhood immunization, we peaked out at about 70–80% vaccination coverage for recommended adolescent vaccinations like measles. You got to over 90% thanks to school laws. So it sort of shows you that, persuasion, education gets you to about 65–75% of people complying. But once you get to the highest hanging fruit, it often is mandates that get people to do what they're going to do. And I think we're going to see the same thing with COVID. Once we have a licensed vaccine, I think we're going to see a lot of places just switch into mandates because it's just, why argue with people, right? I mean, just simply say, look, you want to work here, you get vaccinated. If you don't want to work, if you don't want to get vaccinated, you don't work here. End of conversation, end of discussion. So I think for some of the most hesitant groups, we're going to probably be moving toward mandates and incentives. But there's a lot of work in other vaccination spaces, just not yet applied to COVID, where there is, I think, some opportunities to find theories and frameworks and approaches that work.
So I was wondering about just to throw
I chime in on, sorry.
No, I was just going to say, I was picking up on Glenn's comment in his presentation about the Lancet article, and that we have to be careful about not victim blaming people for being hesitant when there may be reasons for it to be hesitant, and that we need to look at the reasons for hesitancy in a thoughtful way. And the article MMWR that came out yesterday looking at vaccine behavior of senior citizens in this country showed this very strong relationship with the social vulnerability index, so that vaccine rates were lowest in those areas that were most socially vulnerable. And so I guess my question is, and the challenge I think is, how do we strike a balance between individual approaches that may be focused on education or persuasion or behavioral economics or incentives for individuals versus the, the social determinant perspective, when we know that people who are socially vulnerable, who don't have internet, who don't have computers, who don't have transportations, are much less likely to get vaccinated. And obviously the answer is you do both, but that'd be an interesting thing for some discussion.
Hey, I'm into that. And let me just jump in because I'm glad somebody brought up mandates. We're working with a group of historically Black colleges and universities with the idea that, starting a year from now, it takes a while to, get a grant from NIH. But we're working under the assumption that, COVID vax will be mandated for in-person class attendance, like meningitis is already. And, the deal is exemptions, because most of the states, at least in the South, have your personal exemption. And, you can find a website that'll tell you how to do it. And so we're going to be trying to reduce the proportion of students who seek personal exemptions, assuming there's a mandate. Oh, and the other thing on financial incentives, you got to be careful with those, because some of the people I know, if they hear the government is offering you money to get the shot, they are going to be triply suspicious of, communist plot of some kind.
My daughter is working with Georgia Department of Public Health to administer vaccines, and she's at UGA, so she's in Clark County. And she said she was really shocked at the number of people who asked if they would be able to be tracked now based on what she was injecting into their arm.
Oh yeah, Bill Gates is going to track you. I mean, that's really common belief. Yeah. Bill Gates is in hiding right now, I think.
Like, they can't track you with your cell phone, but they can track you with your vaccination.
Exactly. No, and that started in Africa, when the Gates Foundation provided all those vaccines there. Though, as I was saying, most of the African Americans I know have, gotten past that. But I know plenty of Anglos who will, tell me that, and they'll send me to YouTube, that'll show, explain it, that they're going to be tracked.
So how do you overcome beliefs like that?
Well, you find one of them who decided that's not true and let him tell the others, or her tell the others. This is what we call the peer modeling. Because they're out there, they're out there. One out of maybe 15, 20 people I know who were conspiracy theory subscribers have, what's the right word for it, overcome their misinformation. And if you let them tell their story of how that, came to be to other people like themselves, you might be able to persuade them. Audiences are obstinate. That's a famous book, Obstinate Audience, since the 50s. People will counter-argue. And we use this concept of psychological inoculation, where you expose, maybe they're already exposed, maybe they haven't. You expose your audience to the counter-arguments against vaccination that they're most likely to, believe or have heard. And then you find someone like themselves who will refute those and just say, I don't believe it. And I know it works because I see it work in, in real life. What we want to do at Foundry 512 is stuff like buy ad placement to run while particularly offensive YouTube videos open. So you get a role model talking what they're going to tell you, it's not true. Or on alternative social media, yes, like Parler, 4chan, that's where they are.
So where do you think the opportunities are based on all the, we've heard lots of reasons why there's vaccine hesitancy. Where do you think the opportunities are?
Well, I mean, you need funding to do anything, but I think the opportunities are to be funded to experiment with different kinds of social media treatments. I don't like to use the word intervention.
I was just going to add, with Alfred, Alfred and I are peers and go back decades, and don't let the South Texas accent fool you, that Alfred is a world-renowned expert in community health promotion and has really, the peer model and the media integration are areas that he really was a seminal leader in. So we're fortunate to have him on the call, and I'm getting a lot from him myself. I think the last comment though on social media, one of my challenges and where we are and working with refugees is that some of the technology, the social media, Twitter approach is different for refugee communities than it is for mainstream communities, and we need to be more, understanding of the importance of peer-to-peer relationships, trusted elders, and the types of ways they do communicate, which often is more global, back to their countries where they're bringing back even more conspiracy theories than may be prevalent in this country. So I think it goes to something Glenn said earlier about knowing your audience and how they communicate and who they trust.
With respect to social media, I think social media is often a place where people gravitate to, including for interventions. But one of the things some things I think are important to note about the social media is, one, you have to define what exactly you mean by social media, right? Because we often default to the things that come top of mind, and they tend to be Facebook, Twitter, Instagram. With the exception of Twitter, most of those are closed worlds. I mean, it's not people's public Facebook. I mean, yes, some of it, but you can't get into their closed Facebook. In many parts of the world, people use WhatsApp. You can't get into WhatsApp. You don't know what they're saying, what they're sharing. And a lot of these platforms, you don't have any sense of what's being shared among who. And then the other challenge, and this is a challenge primarily, well, it's for public health and for government agencies, even if you're able to get a sense of what's going on in that network, how do you intervene in that network? I mean, it's not something, I mean, it's really easy to use those networks to foment, doubt and misinformation. It is really difficult for government agencies to use those networks to counter misinformation and doubt, with the exception of going to the platforms and saying, you need to monitor your content and pull the plug, because there's really not good ways for government agencies to insert themselves into those social media networks. Now, somebody could have an idea or two.
I've got to make a quick comment on that. You can buy ads on Facebook, YouTube, and you can micro-target them. And of course, you can't intrude on private, conversations on the social media forum, but you can buy ads that when they scroll through their feed, they'll see your ad.
No, and that's good. You're right, and that's a really good idea. And that's the intervention that I don't know that anybody ever tested at scale.
Oh, we're doing a big quit smoking campaign for young adults in South Texas, and we're at scale, and it's really cost efficient to recruit young adult smokers into a Facebook chat app via the Facebook advertising, micro-targeted.
And who's funding it? I assume it's an advocacy group?
It's actually the Cancer Prevention Research Institute of Texas.
Okay. So you see, I think that,
years with this.
Taking that model and trying and bringing it into the vaccine world, I think would be something that would get a lot of attention. I don't think I don't.
That's
know
what we want to do. That's what Foundry 512 is, exactly what we want to do.
But you don't publish your research, so nobody knows about it. Just kidding.
Well, we have a publication.
But you were saying you weren't interested.
It's not in your science journal. It's in an advertising, thought piece. But Aaron or Jesus, have you sent them that Medium piece?
No, but I can share it with the group today.
Yeah, we'll send you that. And we will publish when we get results.
Because I think that's an opportunity. I think that's a space that there would be opportunity in.
Yeah, and initially we've had success with when targeting some of these micro communities or isolated pockets of people is actually fitting the team to the target audience. And we found that that's the best way to communicate with them and to gain insights of where they communicate and where they congregate at. Approaching a situation, trying to target specific micro groups without having anyone on your team that is part of their tribe increases the challenges exponentially because you come off as an outsider and it's very obvious to these groups.
Interesting. Aaron, you want to explain what you posted in the chat?
Oh, sure. That was just a Medium article that Alfred was referencing. Sorry about that.
No, that's good. Sorry, I meant the other Aaron Joy.
Oh.
Sure. That's a 5-minute video on YouTube done by the comedian W. Kamau Bell, who is very well known and very well respected in the Black community, with, I think it's about a dozen Black healthcare workers of various stripes, from nursing assistant to up in the Surgeon General's office, giving all different reasons why everybody should get the COVID vaccine. And it's really well done. If you want, I can play it. But it would be great if we could get a conservative group to do the equivalent for the other audiences. It goes through all of the different misinformation campaigns that are out there that are targeted at African Americans.
I know that the Grady primary care doctors have also done a video for their Grady patients along the same lines. I don't know how effective it's been. What else do you see are opportunities?
This is Karen again. I think this kind of goes along with what other people have been saying. If we do get this this new project, we will be meeting with people with disabilities, people seniors, to get more information about what their hesitancy is all about, or whether it's an access problem or both, and also what forms of communication they would be most receptive to. So we will be collecting some of that information. We'll see what happens.
And the funding's come up multiple times here. And we may not have funding now, but it's one thing that has come out of some of these groups are joint funding applications. So if if you have a group that somebody else wants to study, or you really like what you just heard about buying ads on Facebook, and you want to apply that to your group, it could be that potentially there might be some joint funding opportunities.
Yeah, we looked into how to segment Facebook and get into some of the Facebook groups too. I think we looked at like white motorcycle drivers in Georgia or something like that. You can really get down into segmented population. That'll help you too, but you have to. There's some nuances to it, but I'd be happy to connect anybody interested to the person who's doing the research, because you have to have some level of membership to get into certain groups. But then, of course, you need money too. But if you get the right groups, it should be pretty powerful.
Going back to one of the things I mentioned earlier, like, in our population, we're working with a lot of the, working with their primary care physician and having them encourage them to get vaccinated. It doesn't exist because they don't have access to care. They don't have primary care physicians. They may use social media quite differently along the lines that Glenn was describing, not the common ones, but more either close ones or international ones. So part of the issue, I think, is, not to, the tension between individual interventions versus social determinant issues, social vulnerability issues. How do you strike that balance? But I'd be interested in, particularly Alfred's comment or thoughts about the role of community, that it's not just focused on individuals, that we get one person at a time, but again, part of the work that he's done historically was try to influence community norms and actions through media and through other efforts and policies to move larger groups as opposed to moving people one by one.
Well, Michael, hey, thanks for the kind words earlier too. On the community, Facebook, it is a community. You've got your Facebook community groups for almost every small town in Texas, and you can just get right on it. If you know them, you have to join it or know people who are in it. And, we've got a huge gap between our ivory tower and the actual real people out there. What we're proposing to do in South Texas at the community level is to, not lobby elected officials, because we can't use government money to do that, but to educate the public about the value of mandating vaccination for certain, types of employees and stuff, like teachers. And our particular low-hanging fruit for us is county employees who have frequent contact with the public. We feel it's going to be possible within a year, maybe, to get some counties to, mandate that those kinds of county employees' condition of employment in that public-facing job is to, be vaccinated.
Yeah.
Also, I'd just quickly say there's an assumption we're all working under, which is this vaccine's not going away. And both the shots, we're getting now, those of us who are getting them, their effects are going to wear off. And then we're going to have new variants, mutations that will, may get around, and may even have higher reproduction rates, requiring higher vaccination rates. And so we're kind of assuming for the next, years ahead that we're going to be recommending and making available vaccinations, all the time.
There's a note in the chat from Aaron about funding from HRSA. And I wanted to use that as a jumping off point for the CTSA folks on the call, who are basically universities, and much of the funding, and there's literally billions of dollars that's being put out very quickly, is not intended for universities. It's intended for municipalities or for organizations or for state or local health departments. CDC is putting out $2 billion to state health departments and large locals, and also Minority Health was funding municipalities. And this HRSA grant that's on this chat box now is $120 million, 10 million, 12 million each for 10 awardees for 6 months, but for national organizations or entities that have regional or national scope, which conceivably CTSAs might, but it's due next week. And so it's kind of a crazy world right now in terms of how much money, who's eligible, how it's short a period of time there is to respond to it. So it's a little frustrating, but also exciting. And then, one of the issues I've been trying to raise with the groups I'm in is around sustainability. I mean, this HRSA grant, 6 months. What happens after 6 months, and how do you hire someone to work on a 6-month project?
Well, and a lot of them also want to know that it worked, right? And they want vaccination records. And like I said, getting COVID-19 vaccination records is a daunting challenge, because you can go to literally hundreds of places to get your vaccines, and you go to one place for the first dose and another place for the second dose. Yeah, it's a real tough one.
I do want to echo what Michael said with the RADx initiative. They threw a whole bunch of money at Emory, and then Emory struggled to find enough research nurses and technicians to be able to do the work. And the grant's only for a year. So it was pretty much to divert other people. I think Aaron has also mentioned there's another notice coming out. So there will be another call for smaller community groups. And Erin is offering her center for anyone who's interested in disabilities.
Yeah, we're definitely not a group that would go after this as a lead organization, but if you're interested in that component, we might be able to help in various ways. So if anyone is going after it, what the heck? Send me an email.
So we have 15 minutes left. Usually we spend the last 10 minutes or so discussing next steps for this group. And sometimes it's just that you heard somebody, you talked to somebody today you want to follow up with individually. Lauren can help you with that if you don't have their email address. Sometimes it's create a listserv and share information about this, or I decided I'm going to go after one of those HRSA grants and I'm looking for a collaborator. We can set that up. It may be that you want to get together again and maybe look at some data related to your own work. We've had that as an outcome. It's really up to you, or it can just be that this gave you what you needed in terms of interest in this topic. So let's just talk for a few minutes about that.
One of the things I didn't hear a lot during the call was about what the CTSA is doing in this space. I mean, I think there's people from CTS organizations here who are interested, but is there a more structured or definitive role that the Georgia CTSA or other CTSAs could be playing around vaccine uptake? And
I mean, that's a good question, and I don't know the answer. Mugisha, do you?
Yeah, I don't. I know that with the Recruitment Center, we worked with specific research studies that are interested in like vaccine trials and things like that. But yeah, not on a large scale.
I happen to be married to the head of the Georgia CTSA, so I'm going to go grab him and get him to answer that question for you. But if you would keep talking about what you'd like to do next.
I guess that's one of the advantages of remote working. You can corner your husband in the living room and ask him a question, a tough question.
He's coming. So while I was gone, do you have any other ideas?
Well, I'll just say for Foundry 512, we're acutely interested in funding opportunities. You know, next week deadline for HRSA, I don't think we knew about that. And next week is probably too soon to pull together collaboration with the, regional health department authorities where we do have good aggregate data on a county level. But that's what we would really appreciate. Michael, if you know anything in advance, I'm not really in the, know anymore in terms of inner circles finding out about stuff until, almost too late.
Well, it's interesting on the HRSA one that we're discussing. That was released last week, I think on Friday even, so, or Thursday, maybe Wednesday. It's been out. It's unheard of what they're doing. I mean, it's like a 2-week notice for $120 million grant proposal. They are going to be doing a second round, though. I think it's noted in the chat from Aaron. The first round is due next week. The second round hasn't been announced yet. So I would, they're going to spend another, they got $250 million total. 120 is out there now. The next 120 hasn't been announced yet, but it's supposed to be for smaller community-based organizations. So that's as much heads up as you're going to get, probably. Just keep your eye open for that. So
I will ask Lauren to send the information that Aaron Joy has put in the chat out as an email after we're finished with this call. So this is Bob Taylor behind me. He is the PI of the Georgia CTSA, and I've told him you wanted to hear about what the CTSAs are planning with regard to vaccine hesitancy.
And I have to say, not much right now. There's been some discussion, but I don't think there are any firm plans, either at the national or at the Georgia CTSA level at this point. There was, a lot of effort about trial, recruiting people, particularly underrepresented minorities into the trials, but there hasn't been anything central come out from NCATS about vaccine hesitancy at this point. And I know, I know there's interest and there's discussion, but I don't think anything's firmed up or organized from within the CTSA at this point.
I would just say, it's interesting because I know some of the folks on the call are, good public health people. And, the CTSA, NIH funded, primarily clinical. And so this is an opportunity for integration of public health approaches and clinical approaches, because everything we know is that people listen to their doctors if you have a doctor. And so CTSAs, you would think, would be a good mechanism to get out to providers and clinical sites good vaccine hesitancy prevention messages in keeping with social and behavioral sciences and public health principles. So I think, it's an example of kind of the need for more integration across NIH and CDC, God forbid, Glenn.
Well, the other thing, you're up against a culture, and I saw this when I first joined CDC as the director of communications for the immunization program, which is that vaccines spoke for themselves, that they were so inherently beneficial. You didn't need to have investments in education and communication, and you also had school mandates. And so I think what happened is public health got complacent, just assumed that. They forgot that mandates are made by people and they can be undone and changed by people. They're not like the laws of physics. And so I think that was underestimated. And then as more vaccines came online for things that people were less familiar with, that's when you really needed vaccine education and communication, but you didn't have the infrastructure and the tradition of funding it and doing it and finding out what works. And I think that's been one of the things I've been telling people for the past 5 or 6 years is that, you know, we make all these investments in developing vaccines and the research and development of vaccines, but we don't make any kind of investment in the communications that would accompany those vaccines should they get to licensure and recommendation. And we just assume that people will go, wow, they're vaccines, they must work. But that's not how people default in this country or even most parts of the world. Vaccines scare people and they're a mystery to people. And so we haven't done anything to really to make them less mysterious and get people to understand we use them because we don't have effective treatments. And it's a lot better to stop things from happening than to try to treat them once they happen. So yeah, I think it would be, you know, something, maybe it's something to think about is we've got vaccine development centers at Georgia, at Emory, other places that, you know, maybe we try to figure out how do we put together a coherent proposal to say, we need to have funding in, you know, let's try funding vaccine education and communications proactively.
I mean, I think one of the lessons learned from the trials was sort of the top-down approach didn't work so well, and what worked great was, you know, making use of sort of the existing relationships with the CBOs and, you know, other things through our community engagement groups. And, you know, there was I was on a conference call with NCAPS about when the SEAL money was released, and there was, you know, a lot of real negative response about, you know, warp speed and, you know, sort of this top-down management. And you know, I do think the success in getting it out, getting the trials out on the, you know, focused on a broader group of folks really came from sort of, you know, community-based and established relationships that have been there for a long time. Creating something new on the spot didn't seem to work so well.
So who should we hook someone like Glenn up with in terms of trying to marry a little bit more the communication with the vaccine development? Nadine?
Well, yeah, Nadine and then you know, Lily at Morehouse, and the people that were on the had the SEAL.
Sorry, we have a lot of puppies in the house and we decided to chime in. Sorry about that. We are in fact about out of time, which they're trying to tell us. So, Glenn, if you'd like to pursue that, we can introduce you to Nadine Raphael, who runs the Emory Vaccine Center, unless you already know her.
No, I don't think I do. I know many people. I know Walt Ornstein and Bob Misnarchik.
Yeah, I think Nadine would be, and Lily Immergulek at Morehouse has a similar role in Morehouse. So that might be a good option for you. And then for the rest of the group, we'll send out all the information that's been in the chat. And any other funding opportunities you hear about, if you send to Lauren, she can distribute to the group. Is there anything else you'd like to do in terms of follow-up? Anything else you'd like to do?
I'd be happy to join another call like this if you schedule one.
Yeah, definitely. You already
I said I would be happy to join another call like this.
Okay.
I found it very helpful.
Any other requests? All right, this afternoon. I do hope this is helpful. You've heard something that spurs you to contact someone else in the call or find one of these grants. We do follow up with these because we have to justify spending our time on things like this. So if you get an email from us asking if you initiated a new collaboration or you applied for a grant, please let us know. So thank you everybody for joining us. It's a really rich discussion.
Thank you.
Thank you.